You're listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We'll be joined by cancer experts to discuss blood cancer diagnosis, treatment, survivorship, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. I'm Dr. Ken Miller. I'm a medical oncologist, hematologist, and a Blood Cancer United volunteer. And I want to thank all of you so much for joining us on this episode. Today, we'll be discussing CML, chronic myeloid leukemia, exploring recent advances, emerging therapies, and their impact on patient care, including updates on targeted therapies, resistance, side effect management, monitoring strategies, and the future of caring for our patients with CML. We're delighted to be joined by Dr. Michael Morrow, who's the director of the Chronic Myeloid Leukemia Program and professor of medicine in the Leukemia Service at Memorial Sloan Kettering Cancer Center in New York. Mike, thanks for joining us.
Ken, it's a pleasure, and thank you for the invitation to join the podcast today.
So I wanted to start out, in a sense, 60,000-foot view on CML and really sort of the revolution that occurred.
That's a great question, and it's timely because it's sort of an anniversary year. It's 25 years since imatinib, or Gleevec, was brought to patients back in 2000 and 2001. So CML, I always say it's a very good story, and I'm really honored to be part of the story. If you think back, though, in the 1990s, cancer chemotherapy was more historic in nature, that it was more conventional chemotherapy. We didn't really have much in the way of targeted therapies. At the time, targeted therapy for CML, BCR-ABL inhibitors were developed. We had a few antibodies and hormonal therapy against breast cancer and prostate cancer. Herceptin and rituximab were really the only drugs on the horizon. In principle, we had hoped we could find better ways to treat cancer, and we knew a lot about the underpinnings of CML were the first human cancer linked to a genetic abnormality in 1960. Nolan Huntingford and the humble cytogeneticist Janet Rowley visualizing the Philadelphia chromosome, notorious. But you always stand on the shoulders of giants. A host of scientists really helped unravel what BCR-ABL represented, what signaling was occurring. And my mentor, Brian Drucker, really led the charge to find a small molecule inhibitor, which potentially could disarm CML. And he had that simple approach. If we knew what made the bomb tick, we could disarm it. And he was right. And many people didn't think that was going to hold true or be a lasting story. And indeed it was. And the field continued to show how good that type of therapy could be. And it's now curative, functionally curative for a large proportion of patients. And we have a number of drugs developed since, which have improved upon imatinib or complemented imatinib. And we've left historic therapies behind. So we really hopefully led the charge in targeted therapy. And I'm so happy to see that targeted therapy has populated a lot of cancer treatment. We have a host of targeted therapies across all cancers. We have cross-pollination where one targeted drug in one disease can be used in another because of similarities and overlap and so on. So it's a great story and it's got a great ending, I would say, although we're clearly not done. We have a lot of work to do and work to finish. And again, we've lit the fire around the other cancer communities.
So I have to say, just as a community practitioner, what a fabulous transition it was around 2001. Patients before then, life expectancy, it was limited. And now there's patients that I've been following for years. All of us have, and it's very exciting. I want to ask you a little bit about molecular remission, sort of the best. Every time I treat someone, I actually plan that they will go into molecular remission. But I wanted to ask you about that because as I look at the literature, it's not 100%. With first generation and second generation and third generation, what are realistic expectations for the number of patients who will go into that type of remission?
I think the story of how CML goes into remission and what we count as a functional cure is also quite interesting in that the good news is that the overwhelming majority, near all patients, will have a hematologic remission where their blood counts normalize. And then we see what we call somewhat historic or conventional testing, cytogenetics, normalize in the vast majority, in most scenarios, upwards or north of 90%. But then we're down to molecular responses you were speaking of. And that is the way we gauge response sort of from beginning to end because it's quite sensitive and quite readily available. A blood test tells us the answer. It's not an infinite range of sensitivity, though. It only can see down so low. we have these landmarks we've discovered along the journey, and even starting with imatinib, the scientists who were running the original trials of imatinib needed to birth the landmark of major molecular response because it was really a break point where the molecular response was about 1,000 times smaller than an untreated level. And below that level, people generally never progressed, and they generally had prolonged survival and probably no impact on survival, really, as with further research. And then we started to see patients whose molecular studies either turned negative or were consistently low. We started to see segue into treatment-free remission, where patients can potentially interrupt treatment. I think we're going to talk a little bit more about that. But the likelihood of getting a molecular remission that is protective is high, where patients are unlikely to progress or relapse. The likelihood of getting a molecular remission that's suitable for patients to be considered able to stop treatment is a little less robust than we'd like. I'd say it's probably upwards of 60 to 70% in our best scenarios, maybe more like 50%. So we still have a lot of patients in molecular response where they're protected, but they're still on treatment and probably should stay on treatment. We have a good number of patients who seem to be low enough and stable enough where discontinuation can be considered. And we continue to do more study. Probably the one last comment to make is that the most interesting reality check is that when you look at patients who have been treated, gone into a deep remission, perhaps interrupted treatment, and are stable off treatment even for years, if you go back and with more sensitive testing, do molecular studies on their samples, they're most likely still positive for the BCR-ABL transcript or the BCR-ABL marker. What does that mean? I think we have some very elegant research showing us that may be a persistence in cells that aren't going to cause us the myeloid disease to come back. It may not be a myeloid precursor, a reservoir from which the disease can come back. It may be sort of the mark of the CML in T cells and B cells that aren't clonal, they're not proliferative, except when they expand and contract based on the immune system. Then they may be responsible for the background signal. So it's a really interesting situation.
So I have to say, that's fascinating. Say a little bit more if you're able to. So it's not that the PCR is picking up myeloid cells, it's actually picking up lymphoid cells. How could that be?
So if we imagine the CML story, it happens in a myeloid precursor, which can give rise to all the subsets, T, B, myeloid cells. And you have BCR-ABL clonal disease that's proliferative in the myeloid compartment, but you may have some cells that are terminally differentiated in the B and T cell compartment. They may be long-lived because they're memory cells or they're resident cells. And you treat someone into remission and you've eliminated the myeloid compartment, the proliferative compartment, by exhausting it. But you may still have some of the other innocent bystanders, perhaps, if you will, or other cells that were part of the mix that may not be a threat. They may not cause myeloid disease. There's actually a nice study from our brilliant colleagues in Australia that did very careful sorting of cells in patients in deep remission off treatment and showed this, that if the signal was coming from the T or the B compartment, the relapse signal was much different than if it was coming from the myeloid compartment. And lastly, this is not the only instance of this. There are some acute leukemias called core binding factor leukemias where there's a genetic translocation, which is very prominent and very much a driver. But you can see it in cells that are not proliferative or don't recapitulate the disease beyond remission and cure. So it's not the first time that story has been told where you might have sort of the mark of the disease you had, but not the risk of relapse that you may envision from that.
Well, with that in mind, which is such an interesting story, what should we, meaning we as practitioners in general, be doing in terms of monitoring? And again, keeping in mind that PCR may detect other things or amount of disease that's not going to affect the patient, more than likely. Again, what would be good monitoring? And then let's even transition a little bit further to what do we do about it?
I think because there's some nuance to it, that's a great question, but there's a very good roadmap, though. The good news is that we have very clearly established timelines where we look at response, and our PCR, or polymerase chain reaction testing for BCR-ABL, is probably the most relevant test in CML. It's still important to do a bone marrow diagnosis to understand the breadth of disease and to rule out subtle signs of advanced phase disease. It's still helpful to look at a bone marrow in someone who's got a fairly volumetric persistence or relapse, to look at cytogenetics, some of the classic things we look at in myeloid disease. But if the molecular response, if we track it at 3 months, we expect it to be 10 times lower than untreated. By a year, we want the equivalent of a cytogenetic remission where the disease is 100 times smaller. Then we're looking for that protective remission of a major molecular response, generally within the first 18 months. So the trick is just regular testing. We've done some studies where, for some reason or another, people don't put in the effort to get the PCR done, and it's so important because it allows us to pivot and not just treat a patient who's relapsing or who hasn't responded and is in a bit of danger, but to respond to a patient who's not responding quick enough to, get them up to speed or to pivot before they actually have more risk of danger. So regular molecular testing is really the key. But you were asking a little bit about when we get down to the deeper levels and how do we gauge what we're looking at? What we really want to see is low and stable, probably the way to put it. We want BCR-ABL levels to be below what we call the deep molecular threshold, where the PCR is below a certain level, below 0.01, and it basically continues along that line or below that line for 2 years or more, at least. Longer is, of course, not a detriment. It's only probably a benefit, but there seems to be a minimum requirement before we view people as being treated optimally and potentially a candidate for treatment cessation. Now, that's the optimum scenario. The reality on the ground is that we have a lot of patients that do very well and are protected, but they may have PCR that doesn't get to a deep remission. They may have some wobbling and some variability in their PCR. That's very common. It may not necessarily represent disease growth and regression necessarily. It can be the natural process of extinguishing a clone that can have a little bit of a cyclic nature. Even patients that are in deep remission can fluctuate a little bit, which is unnerving.
Mm-hmm. Yes.
And then lastly, patients sometimes will oscillate between not detected and detected, which is the most unnerving to a patient because they think they went from being kind of in a curative stance to now the leukemia is back. And I always coach my patients in understanding it's really just like the bottom of the radar screen. If we can't see the blip, it might just be below the screen and it's fine. It's just really low. And that's quite common. So this whole story of a bit of persistence or a potential for a background signal plus different places people can land. The molecular monitoring early on is to look for getting into remission. And then later on, it's trying to establish the pattern. And it's not always the same for each patient. But many of them are, or most are in deep remission, are very safe, very protective. And some of them are eligible for treatment cessation.
Let's go back even a step and talk about initial therapy. So it started out with Gleevec, amazing drug, and there was one choice and it was pretty easy. And what goes into your thinking about making that initial decision on treatment? What factors about the disease, about the patient, et cetera?
So we have what I call a really good problem, and that we have a lot of great treatments for CML. And you're right, probably proof principle is that imatinib still is with us today. It hasn't been dethroned. It hasn't been taken off the list. It's actually the drug we know the most about safety-wise and still performs quite well. Nothing really outperforms it with regards to safety, I would say. Adverse events may be a little lower with even our newest drugs. I'll get there in a moment. So we tried to build on imatinib and come up with drugs that would have less chance of resistance and were able to overcome some of the known forms of resistance where mutations and things can occur. And we had 3 drugs developed, nilotinib, dasatinib, and bosutinib. And those are all available both as first treatment or later treatment. They all offer advantages over imatinib, but they all offer probably a little bit different or distinct side effect profile, some worse than others. Some of the problems we see include serious things like vascular disease and cardiovascular risk increasing, worsening of diabetes. Those are some of the things with nilotinib. Dasatinib can cause inflammatory side effects, pleural and pericardial effusions, other inflammatory conditions. Bosutinib just has more kind of, I would say nuts and bolts side effects, GI distress, diarrhea, liver enzyme elevation, and so on. These are manageable, so it may be worth it in many patients, but we were still looking for better. And most recently, we had asciminib or Scemblix approved for frontline use. And that was a different class of inhibitor, still a small molecule inhibitor of BCR-ABL, but targeting it is slightly different. And it showed in comparative trials to be probably, again, more efficient than all of those previously aforementioned choices, all 4 of them, and also somewhat safer with regards to the common side effects we see in the first few years of treatment. So treatment choice comes down to, of course, you always want the best drug with the best odds of remission, best suited to the patient. But that has to include their health, their access to care, their comorbidities or their conditions, their goals for treatment. And these treatments are all highly efficacious. So they're all good choices. There may be difference of opinions on who should be getting what. It's probably a little bit strong to say everyone should receive asciminib because it's probably the drug with the highest efficiency of response and the best adverse event profile. But one could say that, practically speaking, we have a number of options. So it's a conversation. I do encourage patients to go towards asciminib because of its advantages. I do acknowledge that we want to follow it longer. And for example, we can't say we have the safety track record of imatinib over 25 years with any drug. But what this scenario gives us is options to be able to up our game and pivot to a more potent drug if we have any question about response, have multiple options for tolerability questions. We can reassure patients who really do have very strong agendas for cure to maybe we're thinking mostly about the most potent and the newest of our drugs. Whereas for other patients, there may be other options. So complex scenario, but a really good problem. I'll just tell you that a new visit in my clinic, we got to close the door and we do need the whole hour or more because we really got to go through this. And I want people information is power. I want them to know. I want them to be a part of the decision. And I want them to know that even if we decide this today, we have, thank goodness, a lot of plan B, C, D, E as well.
Terrific. Wow. You wrote an article and I would just love to share it with the listeners, but tell us what it was about. It was running a marathon without shoes, or what was the exact title, but it sounded great.
I'm trying to remember what I used that analogy for, but I think it was actually alluding to what we were just speaking about, that CML is a treatment that is obviously individualized. It can be like running a marathon. That's why kind of the analogy I use. I'm a runner myself. I run many marathons. So I think it's helpful for patients. So you need to be obviously prepared. You need to have contingencies for issues that can arise and realize it's going to be a long stretch. So that's why it's so important to fit the right treatment plan for each patient, particularly adverse effects. Many people think of cancer treatment as something short and intense, and I'll have to just grit my teeth and bear it. CML may be a treatment that is very long lasting. So I don't want anyone to have to grin and bear it. I want them to have an optimum quality of life, and us hearing about adverse effects and optimizing and getting to the point where they are very comfortable with their treatment. And of course, we're both comfortable with how they're doing. So running a marathon without the right shoes, if you had a little bit of an irritation, a little bit of an adverse effect, it could lead to a big blister and then you have to stop. So we have to be careful and thoughtful about our treatment choices. And again, we have this great spoil of riches, as many people refer to, with our palette of drugs for CML. I'm so glad to have helped develop them and to see one having a 25-year anniversary this year with imatinib. So that's what that was about.
It's a great analogy, so thanks for sharing it. And it's one I can see myself using both in patients with CML and other diseases that are more of a marathon. So thank you. There may be a patient who looks like they're in a complete response and then they're out of it. And so I have found, and my experience obviously is much, much less than yours on this disease, but I tend to use the word cure. Is that fair? It's a 4-letter word. Do you recommend that we use it or don't use it? Or what do you think?
I think we can. I think the challenge is we keep setting new precedent with CML. First, we had a cancer that we didn't think was curable without a bone marrow transplant. We saw rare patients with interferon long-term response. But then targeted therapy really did seem to put them into a remission that looked like it could be curative. And now we've proven that people have been off treatment for some 10, 15 plus years without any need for retreatment. There's the paradox of the PCR testing and the molecular persistence and all that, but I think cure is a word we can use in that we have great technology to monitor patients. We still monitor them even if they have been off treatment. We haven't stopped yet. And we've incorporated this treatment cessation schema into guidelines and into practice. It's being done in more and more patients, and we're having more and more survivorship in our CML practices. I'm actually quite interested in research in that area to answer the questions patients may have when you may be facing yourself. Ken, now that I've been treated for CML, if you're saying I'm cured, is there anything else I have to worry about? I took medicines for a few years. I did have leukemia. I know that's serious. I'm so grateful I had a good treatment. So we have questions like that. But what a beautiful thing to be able to tell a patient that when you meet them, that our goal is going to be cure. We don't say that's what we're expecting, but then you unravel a bit and say that, but in addition, the chances of you going to remission are hopefully quite high. The chances of finding a drug that's suitable where your quality of life will be near normal is very high. And even if we can't get to a point where we could stop your treatment, the threat from the leukemia hopefully quickly will diminish and maybe even disappear outside of more limited problems. So the C word or the cure word, is often a time-dependent variable. But I think once the patient's been on treatment and then off treatment and off treatment for a few years, they start to get used to it.
Yeah.
And the data with CML is that if you've been off treatment and you're beyond, say, 18 to 24 months, you're probably down to a 5 to 10% at maximum chance under the worst case scenario of needing any retreatment. So the overwhelming majority of those patients the CML is in the rearview mirror now.
Yeah, thank you. Let's talk about resistance. When does it typically develop and how does it develop? And then again, what can we do about it?
We actually fairly early on in CML knew that we might be derailed by resistance that would be based in the way we were trying to treat it. If you have a targeted inhibitor, cancer is by definition unstable. And I always use a lock and key analogy here. So if the drugs we use are the key, the lock would be the BCR-ABL protein. And for most drugs, the ATP binding pocket or the active site, we call it, or for asciminib, the new drug, the myristoyl pocket. But if something changes there and you have a very small molecule with a certain fit or a certain ability to block and inhibit a protein, if something changes, whether it's from drug exposure and selective pressure or just the nature of genetic instability in leukemia, or what we've more recently learned, maybe it's because there are other mutations in the myeloid spectrum, which make mutations more likely to be happening. That's a newish story I can share a little bit more on. So resistance can come from the CML itself, just by its nature, potentially through drug exposure and selection pressure, kind of Darwin's theory of evolution. It may be driven, now we know, from the pressure or the instability driven by other mutations outside of BCR-ABL. And the good news is we can usually sequence and find them. We're actually a little bit more puzzled and we see less good outcomes, ironically, in some studies when we don't have a mutation, when someone is resistant, because we don't understand the mechanism of resistance, nor have we come up with a singular or consistent additional finding that is a mechanism of resistance outside of this breaking story about additional myeloid mutations.
So actually, if you would, just say more about that, because a clinician like myself tends to focus only on the BCR-ABL.
Yes. What we learned recently when we looked at our newest therapies and the more limited numbers of patients with resistance, specifically asciminib and trials with asciminib, when we now use all of our technology to unravel the underpinnings of resistance, we, for example, see that patients with asciminib resistance, which are few in number, might actually have a greater chance of having a secondary mutation like a myeloid mutation such as ASXL1, which is a epigenetic regulator gene mutation common in many myeloid cancers. And that may be fostering greater odds of a BCR-ABL kinase domain mutation. The good news is we have good alternatives to treat the BCR-ABL kinase domain mutations, which can develop, including our readily available drugs like dasatinib and others that may be developed subsequently. So we have a low number, we have a good solution, but we have more of a discrete problem. I actually see that as an advance, that we're getting smarter. We understand how the leukemia may potentially subvert us. So now we can screen for them at diagnosis, and now we maybe have an opportunity to treat someone differently right out of the gate if they have such a mutation. So that's that story, and it's relatively new, and it falls on the heels of all the work that's been done in blood cancers in general, and most cancers, looking at the genetic landscape and heterogeneity and what factors weigh in with regards to treatment response and resistance. Back to the question about resistance itself, there is a fairly straightforward question about what do we know about certain mutations, how they change the protein or the structure, the activity, the access to the site, and which drugs will work. So we have a roadmap. It's not an infinite number of mutations. It's still a relatively small number. So thank goodness we have a handle on that, and guidelines kind of help drive that choice. So that's how we manage resistance. We look at the prior exposure, the degree of disease volume, and of course we look at this question of BCR-ABL kinase domain mutations, and it's sort of a lock and key question. Will this key work for that lock?
I'd love an example, if you can give us one. What would be the most common mutation that comes to your mind, and how does it make the disease unresponsive?
I'll tell you that previously we saw a smattering of mutations, but the better we use our drugs, and I tend to use some of the newer drugs more frequently in clinical trials and so on. So when we see resistance, we still see this mutation called the T315I mutation, which is interestingly drug resistant to many of the therapies we have, meaning it's able to proliferate in the presence of drugs like imatinib, nilotinib, dasatinib, and bosutinib. It's treatable with ponatinib and asciminib, two of our drugs that are available. It's not that it's increasing in frequency, maybe my slice of the CML world, but I do get referred and see cases where that mutation has developed. And using asciminib fairly broadly, starting with the phase 1 trials back in 2013, when you have patients with a lot of exposure, we know that when you have a different class of drug, you can have mutations that develop in a different region. So asciminib has what are called myristoyl pocket mutations, and they're actually fairly uncommon, but I have seen them. And I've had a young woman, for example, a clear-cut case who she unfortunately wasn't as engaged in her treatment, which there are many reasons that go into that. But we were encouraging her to move on to different therapy because she had one of these myristoyl pocket mutations and was on asciminib, and her response was fairly limited. But that unfortunately allowed the disease to flourish, and she progressed to a lymphoid blast phase. Good news is she responded beautifully to chemotherapy and went on to a bone marrow transplant. But it just goes to show that if the right mutation emerges and we don't pay attention to it or treat it, whether it's a myristoyl pocket mutation, a T315I mutation, or one of the other sort of dozen or so common mutations that can evolve, we'll see trouble. Lastly, we do see and know that there's a more complicated scenario where there can be multiple mutations. Now, a cell can't acquire too many mutations, otherwise it'll kind of implode in itself. It won't be able to function. But we can see compound mutations and mutations in both the non-B cerebral and, again, the myeloid compartment. So it's a bit more complicated than the simple lock and key model, but we have a pretty good handle on it.
It was very interesting hearing about the AXL1 mutation. And it makes me think patients sometimes ask, not always, but often will say, why did I get this? What causes the BCR-ABL? Is it perhaps some of these more subtle mutations?
That is a very insightful question, Ken. Wow, because, it dovetails really nicely with this new information. Probably the most interesting data that I'm aware of, which I always share with patients, because I always want to tell them it's not your fault. It wasn't because you didn't live a good life or you had bad habits or you lived on a bad part of the town or the country or something. But intriguingly, some laboratories did BCR-ABL testing, very sensitive BCR-ABL testing on non-CML patients to say, is there a likelihood of detecting BCR-ABL even transient, even low level in non-CML patients? And some of the studies detected it in up to 30% of non-CML patients, meaning if I went out on York Avenue here in Manhattan and just culled 100 patients off the street and did very sensitive PCR, in theory, these studies would show that I could probably detect transient BCR-ABL in many people, which means it's a random error.
Yeah.
Chromosomes 9 and 22 are just close to each other in the cell. So the recombination frequency, the likelihood of an error is high.
Wow.
Patients always wonder, what was the perfect storm that caused it? That we don't know. But intriguingly, this new data probably says, well, some of you use this analogy, which is, if I was a patient, I might not appreciate it, but is it like, the right seed in good soil or bad soil? Or meaning is the bone marrow maybe more or less likely to allow a clonal expansion of a BCR-ABL? And that may have something to do with these myeloid mutations. As we look at our cancer population and our aging population, we know that mutations happen in the blood, just as we age and maybe as a result of other treatments. There may be a clue there that maybe that is a predisposition. So back to the patients, it seems to be probably a bad luck, kind of a lightning strike, I say, for reasons that are not as clear as we'd like. I don't suspect there's a epiphany we'll have with these other mutations, but there may be some clues there. And I was most intrigued by the fact that we can detect it in non-CML patients at the frequency.
Wow.
Yeah.
The topic that comes up is about health economics, and can we afford all this?
So we have many good treatments for CML. And back to your question about how do we choose, especially in the front line, it often becomes a very complicated discussion. And it sort of always includes healthcare economics, which is very important, cannot be overlooked. And I just wanted to urge us to be loyal to the science and to the wonderful advances we've made in this field, to try to incorporate our best therapies as often and as early as we can. This is a disease that can be treated with high efficiency, with a high, hopefully an increasing fraction of cure. I'm hopeful that our newest drugs maybe even increase the cure fraction, which means the lives saved and the quality of life that we're preserving is really worth the cost of some of our newer drugs. And I realize that debate is fairly robust because we have low-cost generics, and we're in an environment right now where a lot of things are in flux and a bit chaotic, unfortunately. But I want to just keep that dialogue, and I hope that dialogue continues between patients and their providers, and providers with industry, and industry with government, and everybody together, because I hate to see barriers that are somewhat arbitrary. And with the full discussion and full disclosure, we have, again, this great problem of having many good therapies and people manage efficiently and be cost conscious, but also aim high and aim for the best.
If you had your druthers, would you ask patients just to stay on the drug or not? And then what criteria do you use to say to a patient, yep, you can stop? And then how do you monitor them?
Very good insight into what people really have to speak about with patients. I'll say first off that when it comes to successful treatment and deciding about treatment-free remission or treatment cessation, I never tell a patient what to do. I always say, we're going to open a door and you can take a peek, you can run right through, you can saunter through, you can pause and ponder. It's a great problem to have a patient that's in a deep remission, hopefully on a drug that they're tolerating well. It's very rare. I give them 3 reasons why we should feel pressed to think about treatment cessation. They're having side effects that are impairing their quality of life. We're trying to escape them. There's impending risk from the drug that they're taking. Hopefully, I would have mitigated or avoided that entirely, but that's sometimes still a possibility. The third one is just the patient's choice. If they are very driven, and many people are, to want to stop. So it's really just a choice. Given my druthers, I would encourage people to think about it. I often get asked, well, what if it was you or your mom or your wife or your daughter? And I would say, of course. It's a remarkable day when we're able to tell a patient, you know what? Okay, today's going to be the day. Maybe it was your last dose last night, or it's going to be tonight or tomorrow. It really is a milestone. It's a safe endeavor. It's not perfect. It's about 50% successful. And that sounds like we haven't worked very hard on it, but that's a decade or more research of thousands of patients. That is roughly 50% successful treatment cessation. My research is in trying to make second or third attempts at treatment cessation possible. Our newer drugs could help with that. And as long as it's done under the right conditions, with careful monitoring and not taken lightly, and of course, at the patient's choice and discretion, I'm all for it.
Awesome. Thank you. And finally, I wanted to ask you about clinical trials and emerging therapies. What are you excited about?
Well, the good news is we're not done. Even though we have such a great repertoire of drugs, what more are we looking for? We're looking for, of course, always different drugs, newer drugs. And there were different classes of drugs in development. One example would be something called a protein degrader. One of my former colleagues out in Oregon, Michael Deininger, has done research in that area and many others as well. So new classes of drugs could be different ways of treating CML, which could be complementary or perhaps better. Who knows? However, we still work in the field of BCR-ABL inhibitors and TKIs or tyrosine kinase inhibitors. And there are multiple new drugs in development. There are what I would call best-in-class active site inhibitors, drugs from a company called Enliven, looking very safe, remarkably safe and highly effective. Drug from a company called Terns, same idea, another optimized inhibitor. This is now another myristoyl-pocket inhibitor or STAMP inhibitor. There are drugs coming out of other countries, a drug from a company called TGRX, which is another allosteric inhibitor, much like asciminib, another STAMP inhibitor, and other small molecules inhibitors of against the active site that have been in development a while and hopefully will still come to fruition. One, for example, that's been approved and used in China extensively called olverembatinib. So there's multiple drugs still in development. There's new drugs classes on the horizon. There's combinations to explore now that we have two different mechanisms of action. We have an exciting trial in our North American CML consortium combining asciminib with ponatinib. Those are our two best drugs. And there are many other studies as well. So new drugs, new ways of using our drugs, still working on how to get to cure for more patients, and of course, survivorship. Those are some of my key areas of interest.
One last question and again, as we were talking, this really came to mind for me, and even from really one of the first things that we talked about, which is how exciting it's been in CML that this class of drugs and new ones have worked so well, and that using the word cure is terrific. What are your thoughts in terms of why this, again, TKIs have not been quite as much a home run? They've been helpful, but not curative in lung cancer and colon and other diseases. Is it the disease? Is it the drugs? What have you thought about?
The story about CML really benefited from the fact that this cancer is fairly singular, fairly predictable, and not as complex as many other cancers. It's driven by a single genetic event that was shown in animal models. And the cancer seems to be really focused and addicted to this BCR-ABL, and everything seems to revolve around that. It's very kind of conceited, I like to call it. And I also like to refer to it because everyone likes to talk bad about a disease, but it's kind of dumb. It proliferates and always wants to proliferate. It doesn't sort of go dormant and then proliferate late. So with treatment-free remission, we don't see patients relapsing 5 to 10 years after stopping. Our therapies have really been best advanced by focusing on BCR-ABL. We have looked extensively for other mechanisms of resistance, and I'm sure there are other things we'll stumble upon and things we've discovered that teach us about advanced phase disease, for example. But that's probably answers your question, Ken, that I think advanced phase CML is what many other cancers look like, that there's probably multiple mechanisms, multiple pathways that are activated already. So while you can inhibit a target, the cell or the cancer can probably quickly pivot and emphasize other pathways or even shed the addiction to what you're targeting.
Yeah.
I think GI stromal tumors was a great example. They used the same family of drugs like imatinib, but mutations were much more likely and much more heterogeneous and impactful against allowing the disease to proliferate and relapse. Even though we had a KIT-driven cancer that was inhibitable by imatinib, it just didn't work the same. So we were lucky in CML, but lucky because we knew what we were dealing with, and it was the right fit for the right disease.
Got it. Thank you. Again, this is Dr. Ken Miller. I want to thank all of you for listening to this really interesting, informative, and exciting episode. I also want to take a minute to thank Dr. Michael Morrow, who's director of the Chronic Myeloid Leukemia Program and professor of medicine at Memorial Sloan Kettering Cancer Center. Mike, thank you so much. This was really a pleasure.
I thank the organization for the kind invitation and you for hosting and everyone for listening in. It was an absolute pleasure.
Thank you. I want to thank all of you for listening to this terrific episode and for a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources. Please visit bloodcancerunited.org/CE. For any questions or to refer a patient to Blood Cancer United, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one help for patients to better understand their disease and treatment, access financial and support resources, and navigate challenges like medical debt, insurance benefits, denials of care, and out-of-pocket costs through the Medical Debt Case Management Program. And I encourage you to learn more about the eligibility criteria and refer your patients to this program. Blood Cancer United also provides other resources for patients, survivors, and their families that can be found at bloodcancerunited.org/support. And I encourage you to sign up to receive notifications of future podcast episodes by subscribing at treatingbloodcancers.org. If you have suggestions for future episodes, please click the feedback button on this episode page. We look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archive section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with Blood Cancer United by following us on social media and access our healthcare professional continuing education activities by visiting bloodcancerunited.org/CE. Let's keep the conversation going. Until next time.